Competency 4.10. Observe and describe the indications for and steps involved in myringotomy and myringoplasty. So this competency is going to cover skill domain. The level of learning is knows how. It comes under core competency why. Suggested teaching and learning method is DOPE session, that is demonstrate, observe, assist and perform by student. It is assessed by written or viva. To the topic myringotomy. Indications: acute suppurative otitis media, severe earache with bulging tympanic membrane, incomplete resolution with opaque drum and persistent conductive deafness, complications of acute otitis media, example facial paralysis, labyrinthitis, or meningitis with bulging tympanic membrane, recurrent acute otitis media with effusion, aero-otitis media, atelectic ear. Steps of operation. Ear canal is cleaned of wax and debris. Operation is ideally performed under operating microscope using a sharp myringotome and a good suction apparatus. In acute suppurative otitis media, a circumferential incision is made in the postero-inferior quadrant of the tympanic membrane midway between the handle of malleus and tympanic annulus, avoiding injury to the incudostapedial joint. In otitis media with effusion, a small radical incision is made in the posto-inferior or antero-inferior quadrant, and all the effusion is sucked. This is the picture depicting myringotome, and here are the two incisions: circumferential incision used in acute suppurative otitis media and radical incision in serous otitis media. So when the ventilation tube is to be inserted, the incision should be just enough to admit the tube and is preferably placed in the antero-superior quadrant for longer retention. Topic is myringoplasty. Indications: restoring the hearing loss and in some cases this tinnitus, checking repeated infection from external auditory canal and eustachian tube, checking aeroallergens reaching the exposed middle ear mucosa leading to persistent ear discharge. Steps of myringoplasty: underlay technique and overlay technique. Underlay technique: harvesting the graft, preparing the tympanic membrane for grafting. An incision is made along the edge of the perforation and the ring of the epithelium is removed. Remove also a strip of mucosal layer from the inner side of perforation. Inspecting the middle ear. A stapes type incision is made and the tympanomeatal flap raised to see the integrity and mobility of the ossicular chain to ensure that no squamous epithelium has grown into the middle ear. Placing the graft. Middle ear is packed with gel foam soaked with an antibiotic. A proper sized graft is placed so that its edges extend under the margins of the perforation all round, and a small part also extends over the posterior canal wall. Tympanomeatal flap is replaced. An underlay technique has the advantage that the squamous epithelium is not buried in the middle ear. This is the picture depicting the underlay technique. The fascia graft is under the anterior annulus. It is supported by gel foam in the middle ear to prevent medial displacement. Next is the overlay technique. The temporal fascia or the pericondral graft is harvested as depicted in the previous slides. Incision is made in the meatus and the meatal skin raised along with the epithelium from the outer surface of the tympanic membrane. Remnant is preserved to be used later. This is the picture depicting the overlay technique, where in the first picture we can see the incision to raise middle meatal skin with tympanic membrane epithelium. Second is placement of the graft. Third is the replacement of the skin. A graft placed on the outer surface of the tympanic membrane. A slit is made in the graft to tuck it under the handle of malleus. Meatal skin removed earlier is now replaced, covering the periphery of the graft. The ear canal packed with gel foam and then with a small antibiotic pack. A modification of the overlay technique is to place the anterior edge of the fascia graft under the annulus after removing the epithelium from its under surface. This prevents the blunting of the anterior canal, which is seen as a complication of overlay technique. Then closure of the endiural or postiural incision and mastoid dressing. This completes the procedure. This is a picture depicting underlay and overlay technique. Thank you.